All right, so we are talking about shock today, and what we're going to do is you got to tell me, how many types of shock are there? There are 4 types of shock. Very good. So what we're going to do is we're going to talk about every type of shock and take a look at the hemodynamic profile. But before we go into that, so when we do a PA catheter, a pulmonary artery catheter, what we're trying to get at is end diastolic, left ventricular end diastolic volume. That's what we're trying to get to. The ideal, if you can measure left ventricular end diastolic volume, so that is, so what's the stroke volume? So if I could measure left ventricular end diastolic volume, what's the stroke volume then? How would I find that out? If I knew what LVEDV was, how would I find the stroke volume?
You'd also need end systolic volume, and then you could measure the difference.
Close. You'll need the ejection fraction. Right? Because the ejection fraction is 50%. That means the LV pumps out 50% of the left ventricular end diastolic volume, right?
Sure.
So if you can get the LVEDV multiplied by the ejection fraction, that's your stroke volume. We can't measure LVEDV easily, if at all. So what Kira is writing is that what we estimate LVEDV by is LVEDP, left ventricular end diastolic pressure. That's very difficult to get on a regular patient. You have to go to the cath lab. So what we do is then we estimate left ventricular end diastolic pressure by the capillary, the pulmonary artery capillary wedge pressure, which is estimated by the pulmonary vein pressure, which is estimated by left atrial pressure, which is estimated by CVP. So I say that because when we measure a CVP, that is a humongous fudge over hemodynamics. So it helps, gives you an idea, okay, if somebody's CVP is -1 and they're hypotensive, they're likely intravascular volume depleted. But know that when we're making all these inferences, we're making them based on estimates. And we're assuming that they're all one column of fluid from the left atrium, from actually the right atrium, all the way to the left ventricle. We're assuming it's one column of blood. And that assumption many times is not actually accurate. Okay? So just to understand when we say all these things, these are all estimates, and you have to be aware of that. Okay? So that said, we have 4 types of shock, right? Now, when we measure hemodynamics, there's kind of 2 or 3 things that, oh my God, my Siri. No, monsieur. My Siri's in French, so I can practice. We want to when we go through hemodynamics, we want to measure central venous pressure. Remember, because again, it's an estimate of what's going on. We want to measure cardiac index. What's cardiac index?
Output divided by stroke volume?
No, it's cardiac output divided by body surface area. So what cardiac index does is it normalizes for body habitus. A cardiac output of 5 in you will be different than a cardiac output of 5 in you. It will be different than a cardiac output of 5 in me, cardiac output of 5 in him, cardiac output of 5 in her. So when you normalize for body surface area, now a cardiac index of 2 may mean a cardiac output of 5 in her. Oh.
It's not ours. That's...
Okay. No problem. So a cardiac index of 2 in you may mean a cardiac output of 5, but in you it might mean a cardiac output of 7. In me it might mean a cardiac output of 7.5, so on and so forth. But the cardiac index of 2 is adequate. right? So that's why we measure cardiac index. And then we have something called systemic vascular resistance, right? Which is, remember, I don't know, I did electrical engineering in college. So, you know, voltage equals V equals I, you know, IR, right? V equals I over R. So it's the same thing. So, systemic vascular resistance is your mean arterial pressure minus your CVP over cardiac output. And that tells you how vasoconstricted or vasodilated your systemic vasculature is, your capillary beds. Okay, so those are the main kind of things that we look at for hemodynamics. So you said 4 types of shock. Name one of them.
Septic or distributive.
Distributive. Okay, so distributive shock. So what would be the hallmark? So what would be the CVP in distributive shock? Would it be low? Would it be normal? Or would it be high? So if maybe you can create a table, put the shock on one end, and then your CVP, cardiac index, SVR.
Like your check mark, yeah.
Yeah. So distributive. What would CVP be in distributive shock?
So
Low, normal, or high?
it could be high to compensate the low SVR.
Mm-hmm.
Or yeah. Or yes.
So CVP could be low, could be normal, could be high. It's either one, right? So, yeah, it could be either way, all right, in distributive shock. How about cardiac index in distributive shock? What would be cardiac index in distributive shock? It could be high or it could be low, right? So it could be either one. Sometimes you can have up and down. What's the hallmark of distributive shock?
Vasodilation.
So the SVR would be
Low.
super low. Exactly. That is the hallmark of distributive shock. Super, super low SVR. Okay? That is, all the others could be equivalent, but it's SVR. SVR is super, 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 super low. So that's what you gotta know about distributive shock. Now, what are the examples of distributive shock? Septic is one of them. How about another one? Anaphylactic. How about another one? You definitely will see them here. Neurogenic, right?
Yeah.
After a high cervical injury, you get distributive shock. Okay. Also, post-op cabbages. Many times they have distributive. They have because of the cardiopulmonary bypass, it causes distributive shock. Okay. So that's distributive shock. Okay. Second type of shock.
Hypovolemic.
Hypovolemic shock. Very good. So CVP, high, low, or normal? That's a trick question. What do you think it would be? And hypovolemic shock.
Decrease.
It'd be low. Yeah. Yeah, CVP will be low. How about cardiac index?
Low.
Low. Mm-hmm. How about SVR?
High.
High. Very good. Very high.
Yeah.
Right? All right. Third type of shock. You get one, and then you get the last one.
Cardiogenic.
Cardiogenic. Very good. CVP, high, low, or normal?
Low.
Could be low or it could be high. Typically it's high. If you have cardiogenic shock, typically it's high, right?
Okay.
The heart's failing.
Yeah.
Think about the heart failing. Acute heart failure, right? So CVP will be high. How about SVR?
It should go up.
It should go, SVR should be up. Yep. How about cardiac index?
That would be
Down, would be low. Mm-hmm. Now, the last type. There's one more. Let's see if you can know it. So we got distributive, cardiogenic, hypovolemic. What's the last type of shock?
Obstructive.
Obstructive. I love it. Good job, man. A lot of people are like, septic, and they're like, no. Obstructive. Okay. CVP, high, low, or normal. And give me examples of obstructive shock. What would be an example?
A clot. Like a PE.
A PE. Very good. What's another example? The pacemaker. That's a clue.
Pacemaker.
Tamponade.
Tamponade. Sure.
Okay. tamponade. Those are the two main types of structure shock. Okay, so CVP will be high, low, or normal. Think about tamponade or PE. CVP would be high, low, or normal.
High.
High. How about cardiac index?
Low.
Low. How about SVR?
High.
High. Very good. So now look at cardiogenic and obstructive look exactly the same. So how can you tell the difference? It's by history. So you go to a rapid response, he just got a pacemaker and he's in obstructive shock. You're thinking tamponade as opposed to acute MI, right?
Yep.
Or somebody just came back from a long haul flight from Paris and collapses and is in shock.
PE.
You think of PE, right? So history will help you to tell the difference between the three. Now I didn't mention wedge because really I don't really use a PA catheter anymore. I really don't, because I have other non-invasive ways that are better. And again, for a pulmonary catheter to be accurate, you have to be in the West zone 1, 2, or 3. You know the zones, the lung zones of West, Dr. West?
3.
3, exactly. Where there's a continuous column of blood from the left atrium through the alveolus into the left ventricle, from the right ventricle through the alveolus into the left atrium. In any other zone, there is not a communication. So depending on where you are in the lung, you're in either a West Zone 2 or a West Zone 1, and there's no continuous column of blood. And when you're intubated, that's even further thrown off. So that's why a PA catheter, we don't use it. In critical care, we don't use it anymore. Like I can do non-invasive, I can do other things and figure it out. Now we have point-of-care ultrasound, which you're looking at the heart, okay? And if the heart is hyperdynamic, you're dehydrated, right? So we're critical care are past pulmonary catheter. When I was a fellow back in the ancient times with the dinosaurs, we used to do pulmonary catheters. Not anymore. We put on everybody. Everybody got swung. And they were fun. They were middle of the night. There was a blast to do, but they did study. 50% of cardiologists couldn't interpret a pulmonary catheter correctly. Yeah. Anyway, and if you can't interpret the numbers, then it's useless test. And then they did study that showed no improvement in outcomes. Well, yeah, if you don't know how to interpret the test, you're not going to be able to improve outcomes. Now, we talked about this earlier. So one of these hemodynamic parameters has a correlate in the blood pressure. We talked about this. Which one is it? So one of them, CVP, cardiac index, or SVR, has a correlate in the blood pressure number. So which one?
1 in 3 chance.
You have a 1 in 3 chance of being correct.
It was SVR.
SVR. Which number in the blood pressure does it correlate to? The diastolic blood pressure. Exactly. So in a high SVR state, which is 3 of the 4, you are going to have a narrow pulse pressure. 68 over 52. 75 over 61. 101 over 82. Something like that. Very narrow blood pulse pressure. That tells you that you have very, very high SVR. That the systemic circulation is completely clamped down to try to shunt blood away from the splanchnic circulation, away from the kidneys, away from the skin, away from the bowel, away from everything, to preserve heart to the heart and lungs. Okay? That's why they're modeled and cold, and that's why they're going to kidney failure, right? Because everything else is being sacrificed to preserve perfusion to the heart and the brain. Right? The only one, again, where you'll have a wide pulse pressure is SVR, distributive shock. So somebody comes in, again, if they're septic, you're going to see. Remember that patient. There's like 114 over 40. Now, if you have aortic insufficiency, you'll also have a wide pulse pressure, but that's separate. In distributive shock, somebody with right after heart surgery, you'll find them to have a very low diastolic pressure. Septic shock, you'll have a very low diastolic pressure. what was I going to say? Anaphylaxis. They'll have a very low diastolic pressure. So just without even knowing anything about the history, anything, all you got to do is look at the blood pressure, and it'll give you a clue as what's happening. And then you'll look brilliant. You walk into their infection, they do, doctor. How did you know that? And you just don't say we learned about shock. Just be quiet and bask in the glow of your brilliance. But to me, you're not brilliant because we just talked about that. Okay, so that's the key. That's the key. The key is to look at that's going to really help you, especially when you don't know anything about the patient. You walking in and they tell you, Doc, we're called the rapid response because the blood pressure is 60/30, 60/20. That'll tell me that, oh, maybe this person's septic, as opposed to 60/48 or 60/50, right? And if you have a low blood pressure with a normal map, that tells me that they're intravascular, that they have a high SVR. You know, 70 systolic, but the map is 61. That tells me that they are intravascularly volume depleted, or they have a high SVR. And you treat accordingly. If they're intravascularly volume depleted, you give them volume. If they're bleeding, you give them blood. A lot of blood, if they're actively bleeding. It's just amazing how you can save somebody if you treat an actively bleeding patient with blood and stop the bleeding. You know, it seems like, obvious, but you know, when you have somebody in hemorrhagic shock and, you know, they're giving 1-2 units of blood, that's not enough. It's not enough. Patient you have to adequately resuscitate them. When they come in, you know, sick and they haven't been eating for 3 days and they're in diarrhea for 5 days because they have C. diff, and you give them a cup of coffee, they're not going to respond to that. They're not going to respond to the 250 cc bolus. They're not. It's a cup of coffee that you're giving over an hour. You're sipping over an hour. That's not going to help them. You're not helping your patient that way. Okay, questions?
Speaking about resuscitation, what are your endpoints of resuscitation? We resuscitate to a target. It
depends. There is goal-directed therapy. I think sometimes I'm trying to stop them from being hypotensive. That's my target, right? I don't necessarily target to a particular cardiac index or specific CVP. We're stopping them from becoming hypotensive as soon as possible. Now, if that means that you're resuscitating and doing vasopressors at the same time, that's a great question. If you're resuscitating if you need pressors and volume at the same time, do it. You want to minimize the time that they're hypotensive. But do not sacrifice, because with norepinephrine, I can make the number look amazing. Okay? I haven't treated the patient. Someone's tachycardic because they're starting to bleed occultly, okay? I can give them low pressure and the number looks fantastic. I'm not treating the patient. Treat the patient, don't treat the number. Treat the patient. It's one of my rules. Treat the patient, don't treat the number. Okay, I had a guy, we were transferring out for ECMO on COVID, and they kept calling me about the heart rate. And I said, I don't care about the heart rate. And they kept calling me. So to shut up the nurse, I said, give low pressure. And then they called me 5 minutes later, blood pressure's low. And I said, start levo. Do you see how stupid that is? Like, don't treat the number. I don't care that they're tachycardic. You know, patients with DKA, they will be tachycardic all the time, for days on end. It is fine. When they come in, you better blast them with a lot of fluid because they are super dry. But once you give them 6-7 liters, they're out of DKA, they're better, they're still going to be tachycardic. It's okay. Okay? They're still going to, if they're tachypnic, when they come in, that's good. You want them to be tachypnic. You don't want them to intubate them, because if you do that in a DKA patient, you'll kill them. Because the compensation that they're relying on, you just get rid of by giving them propofol and sucks, or etomidate and sucks. Now their pH, which was 7.0, was now 6.6. And they arrest. Because you did that to them. Because you didn't understand the physiology of DKA. Not you, not them. Just in general. So, treat the patient. The target is to stop them being hypotensive and treating whatever it needs to be. And now sometimes you can't. Like sometimes distributive shock, we're fighting the inflammatory cascade we're not gonna. We're just trying to minimize them from being hypotensive. But sometimes it needs multiple vasopressors, and sometimes it gets better. Sometimes it never gets better. If we have a septic patient and they're not improving, maybe we don't have source control. Right? We have to have source control. Otherwise, if you have an infected line, you could do anything you want. Nothing will get better until the line comes out. Or an infected pacemaker lead, or an empyema, or an abscess, or whatever it needs. Source control. So yeah, they may never achieve the target. So there have been studies about goal-directed therapy, and you want to target to a specific cardiac indexing. I just want them to stop being hypertensive.
Are you looking for, like, typically we say MAP of 65?
Yeah, usually
Yeah,
a map of 60,
65.
65.
The parameter, we're saying hypotension, but
Urinary.
I think
kind
a-
of how,
I think
kind
a-
of what we use in general nowadays is
Yeah.
you're saying avoid or stop the hypotension, so it's trying to get at least a MAP that's known to be good perfusion.
I agree. So a
That's
map
the
of 60,
parameter.
65. So for sepsis, the studies say 65, which is why we use 65, right? Does that mean that 60 is worse than 65? No. Has it been ever studied? No. I feel like doing a study, to be honest, to compare a map of 65 to a map of 60 and seeing if there's any difference in outcome. I bet you there's not going to be. But at least a map of 60 is adequate to get to
Permissive hypotension, in a sense, right?
It depends. If somebody comes in when they're normally, doc, I'm always a blood pressure of 80.
Yeah.
Okay, you don't need them to be 120 over. That might be hypertensive to them. Or somebody that normally lives at 160 all the time because they don't take their antihypertensive medications, and they come in with a blood pressure of 90, that's low for them.
Yeah, that MAP of 65 may not actually perfuse their kidneys like they're used to.
Exactly.
So may need a higher.
It's so, I think it's important for us to kind of keep the patient in mind. Always treat the patient, always keep the patient in mind. If somebody's asymptomatic, like literally asymptomatic, their blood pressure is 80, but they're watching television, they're looking with the remote control. I don't panic. I'm like, it's okay. They're completely. Now, asymptomatic means they get up and they're not become syncopal, right? So we don't do that all the time. We don't get them up. But if they're in 85 and they're asymptomatic, then you don't have to throw them on levo all the time to get the number better. Not always. There are a few numbers that you have to treat. Potassium at 8, you should always treat that. Okay? But other numbers, not necessarily. Stop, don't panic, and think about what's going on, what's happening to the patient, and treat the patient, not just necessarily a number.